I'm Dr. Michael Reilly, a head and neck surgeon at MedStar Georgetown University Hospital, specializing in facial plastic and reconstructive surgery. I see a wide variety of facial plastic and reconstructive surgery patients at Georgetown. Primarily, it's people dealing with either a nasal trauma, a facial trauma, a combination of issues with cancers in the face, melanoma, the skin of the face, and then I do take care of quite a few patients with facial paralysis. I really try to treat every single patient like they're a family member or friend. I think to myself, what would I be doing if this was my brother calling me with this problem or my mother calling me with this problem? I think that has been the guiding light for me as in terms of my practice and the way I take care of patients from the word go, and it hasn't changed. When I was in medical school, I really fell in love with the anatomy in the face and the head and neck area. So that boiled a specialty down for me pretty quickly to something above the clavicles that I would want to specialize in. But particularly with respect to the face, I realized pretty quickly in medicine and really in life that this is really a person's window to the world, is their facial function, facial structure. It's how they interact with others and how others interact with them. And I find that power of communication to be such an incredible gift that we have as humans that I think that's the thing that primarily gravitated me to the field. I think the thing that gets me the most excited about facial plastic and reconstructive surgery is the way we're never accepting the current status quo as adequate. So it's a field of a lot of pioneering and changing over time. And whereas in the past, someone with a cancer treatment may have been treated with a reconstructive surgery, it was more about just kind of getting the repair done, getting the defect fixed, so to speak. Whereas now, our whole goal is really quality of life. You know, we keep pushing the envelope to try to make things that much better. My goal after a reconstructive surgery is to have a patient who you can't even tell they had reconstructive surgery. So I think that's just going to become more and more likely as we get better technologies, better patient individualized care where we can plan the surgeries with virtual modeling and the tissue maneuvering that's going to be necessary to get the best result for that patient. There is nothing better than a patient who's doing well. There just is nothing better than that. A happy patient is my joy at my job. And that comes in a bunch of different forms because I take care of a wide variety of conditions. It can be something as simple as a nasal fracture patient who had a crooked nose that I've now corrected and is very happy about the way they're breathing and looking again. Or it can be from someone who had an enormous surgery for a cancer and they've been through the ringer with treatments and ongoing recovery, and then they finally get back to me and tell me that they just had their first full meal in a long time, and that was because we were able to repair an integral part of their swallowing mechanism. So it really runs the gamut, but it's those happy patients that keep me getting up every day for sure. I trust the doctors and nurses and staff at MedStar Georgetown University Hospital. I've had my own care there, I send my family members there, and I think that trust from being on the inside and knowing really the ins and outs of how a hospital works and who the people are behind the screens at the hospital and who the people are making the decisions and what the beliefs are and how authentically we do believe in caring for people is why people should come to MedStar Georgetown Hospital. Sudden facial palsy has a few main causes. I think of it as being able to be divided into about 4 categories. The first one is a reactivation of the herpes simplex virus that causes canker sores. The second is a reactivation of the varicella zoster virus that causes chickenpox. The third is a reactivation of the varicella zoster virus that causes chickenpox but does not produce the characteristic rash that we think of with that condition called Ramsay-Hunt syndrome, and therefore often clouds the pictures for people who are trying to treat the condition. And the fourth one is other causes, the primary of which is Lyme disease or exposure to a bacterial infection. So differentiating the category of exactly what the cause of facial paralysis is has been notoriously difficult and really clinically very challenging for most providers, which is why this term of Bell's palsy has taken hold and exists because it just is a catch-all term for anybody who has facial paralysis. We don't know why. But the reality is there is a reason, we just don't know why that reason is. And there have been some studies that have really tried to tease out what percentage of these cases are coming from each of those four things that I mentioned. At the end of the day, we believe that about 55% of these patients are probably experiencing facial paralysis from herpes simplex virus reactivation. That's the canker sore virus. And those patients are likely to have a better recovery. But based on other studies that have been done, there are probably about 40 to 45% of patients who are experiencing a reactivation of the chickenpox virus. And we know from the data on the chickenpox reactivations where there is actual shingles that's visible with the rash and the vesicles that are known and associated with that condition called Ramsay-Hunt syndrome, that those people have a much worse outcome. The tricky part is we think that about 2/3 of the people who have a reactivation from the chickenpox virus don't ever get that rash because they present to the doctor early enough to get the treatment that actually suppresses the onset of the rash. And so they're treated in this Bell's palsy category, not really being treated as a Ramsay-Hunt syndrome patient, therefore not really being considered to be a high-risk group, even though they are because they've gotten the treatment early on. And that's one of the groups I feel like we have the most opportunity in, because if you have a patient where they're having any significant pain, any severe symptoms that are in addition to the facial palsy, dizziness, hearing issues, ringing in the ears, that's associated with the facial palsy, that are kind of classically associated with that chickenpox reactivation, the zoster version, those patients probably need more aggressive therapy, at the minimum, more antivirals than they're getting. Facial paralysis can happen to anyone, but it certainly has certain groups that are more likely to experience a condition. Diabetics, unfortunately, are, as well as people who are immunosuppressed. And then pregnant women are a group that's lesser known, but are also likely to suffer from facial paralysis at an increased rate. We don't know exactly why pregnancy induces facial paralysis more frequently. We think it's probably a combination of the stress on the body that occurs when your body is also taking care of another body, but also just the hormonal changes that occur with pregnancy and whether or not that somehow plays a role. So the verdict is out on that, or the jury is out, but it does seem certainly to be something that happens late in pregnancy to a fair number of women. So Bell's palsy has been a catch-all term for many years to refer to facial paralysis of sudden onset that has what's called an unknown cause or idiopathic cause. That means that we don't really know what's happening when those people present, but we have a feeling, at least that what's always been postulated, is it's a virus that's reactivating in your body. Many people think it's a herpes simplex virus, so that same virus that can cause cold sores around the lips when that time of year comes for various individuals. That nerve is actually just one of the cranial nerves. There are a lot of other cranial nerves where this virus can hang out and cause trouble. Now, the difference is that there are a lot of people who are actually getting a more severe form of facial palsy that results in complete paralysis. And there are studies been shown that when you get the facial paralysis from the reactivation of the herpes zoster virus, which is the chickenpox virus that also causes shingles, most people know about that condition, that causes a pretty severe variant of facial paralysis and results in less than satisfactory conditions in a large majority of patients. So those are the two main things, and there's an importance. I think one of the things that I like to help people understand is that not all sudden facial paralysis is Bell's palsy or the one that you don't need to worry about. And unfortunately, these days, we don't actually yet have a way of determining exactly what is the cause. So in my practice, I like to treat everyone like they have the more severe zoster mediated facial paralysis until proven otherwise, because the treatments are different for the two conditions. Diabetes is a condition that often affects the nerves. So one of the commonly known things about diabetes is that the sensory nerves don't kind of work as well. People's fingertips and toes are less sensitive than they are in a patient who's non-diabetic. But it can also affect other nerves like the facial nerve. And so the likelihood is with the diabetic patient that you get the same problem, which is a viral reactivation in the vast majority of patients, but your nerve is already kind of a little bit brittle and doesn't recover as well as other patients do. The other thing about diabetes is, frankly, that they're immunosuppressed. I mean, the diabetes itself, especially poorly controlled diabetes, is an immunosuppressant. So when you have elevated blood sugars, your body is not able to fight viruses and infections like it can when it's got the normal homeostasis and the normal balance in sugar. Diabetic patients, unfortunately, are a group that I think is an area where we could actually make some difference, because there are a number of diabetic patients who are counseled against steroids because of the risk that it can have to increase their blood sugars. But we know that if we were aggressive about managing their sugars with the necessary medications, we could actually put them on steroids and manage their sugars at the same time. So I think that's one group where certainly getting a more robust care plan in place at the very beginning, rather than just accepting that they're not able to get the high dose of steroids, is probably would be ultimately beneficial for them. My advice for anyone who's suffering from an acute facial paralysis, a sudden facial paralysis that's been not determined to be a stroke or other cause, but it's been determined to be one of these unknown causes, is to seek the care of a facial plastic expert immediately after their initial diagnosis. So it's absolutely normal and expected that someone who has this condition, which is pretty unsettling, would go to an urgent care or their primary care doctor for the first available appointment within that day or so. But once that diagnosis has been established, I really believe that you should seek out the care of someone who takes care of this condition all the time. Someone who really understands what you're dealing with and who understands the nuances of those that may get full recovery and be likely to get full recovery versus those who are actually on a path to a less than satisfactory recovery, so that we can implement things early to help mitigate that risk. First, I think it's important to know what is the chance of getting facial palsy in your lifetime. And believe it or not, it's about 1 in 70 patients. So 1 in 70 people over the course of their lifetime will experience this condition known as idiopathic or facial paralysis or Bell's palsy. And the chances of getting recovery are good, but they're not perfect. They're actually far from perfect. A patient who suffers from a sudden onset of facial paralysis has about a 70% chance of getting a return to full recovery. And that's assuming that they get immediate care with the currently accepted standard regimen, which is about 10 days of steroid treatment with or without a week of antiviral treatment. So that still leaves us with somewhere, depending on which study we're looking at, between 25 and 29% of patients who don't get full recovery. And that can lead to various forms of facial dysfunction, difficulty moving the face, unnecessary, unwanted movements of the face when you're not trying to, or other disfiguring things that can occur when you're not able to eat or speak properly. When people ask about physical therapy for facial palsy, I equate it to other parts of the body that you might have sudden injury to. You know, if your arm was injured and it was in a cast for 6 weeks, well, what you do afterwards is you go to a physical therapist to get things moving again. Our muscles are meant to be moved. We have 46 muscles in the face. These muscles can go completely still and stagnant for a long period of time with sudden facial paralysis. So I really think the point of facial physical therapy is keeping those muscles pliable and loose and mobile, so that when the nerve does come back, the muscles are ready to accommodate that nerve function again, and they're not sitting there stuck in a rigid form that they've been unable to really move for the past 6 weeks or so. And so I always say physical therapy for facial paralysis is what I would do, is what I recommend, because there's not really any downside to it, and the only thing is the upside of making sure that you're keeping those muscles mobile and ready to get reinnervated when the nerve starts to recover. So for sudden facial paralysis, the treatment that we absolutely recommend for anyone who doesn't have a contraindication to steroids is an immediate course of steroids. The common prescription is for 10 days of steroids. That's not been studied in terms of the degree of effect from that amount of steroids versus a longer treatment or a shorter treatment, but that's kind of standard issue medical practice in this nation. And we actually have studies undergoing right now that are figuring out what are the practices, because it is kind of all over the board. There isn't one kind of paradigm for treating facial paralysis. But absolutely, getting on a steroid immediately and getting on a high-dose steroid is indicated for those who can tolerate it and without other medical problems like diabetes, which sometimes makes it a little bit difficult to be on a steroid. So that's the first thing, is to get on that steroid. It's really important. And I will tell you that in my practice, I will often prescribe a longer course of steroids based on the science of how the facial nerve works. So we know that there's irreversible damage to the facial nerve if it's got more than 3 weeks of non-function. So by 3 weeks, if the nerve isn't already coming back, then there's likely to be some long-lasting, durable effect that's untoward. And so by getting people on steroids right away, I think it's important because it decreases the inflammation in the nerve. But by keeping them on steroids for at least my practice, a minimum of those first 3 weeks when we know that nerve is really at its most vulnerable, I think isn't really indicated. The next thing is to get people on an antiviral medication. In the big studies, they've really shown a negligible improvement in facial paralysis outcomes from people who are on antiviral treatment. But the caveat to that is that the antiviral treatments that have been used in those studies are a 1-week course of antivirals. And what we know is that when people have a viral reactivation from either herpes simplex or herpes zoster, the two main viruses that cause facial paralysis, the likelihood is that their immune system is going to take at least 6 weeks to mount its optimal response to those. And so until there's a study proving that 6 weeks of antivirals don't help, my tendency is to put people on antivirals until they start to show improvement, and often even longer than that, until they're fully recovered. Another treatment that's definitely on the horizon, and there is some recent literature to support, is the use of something called a calcium channel blocker, which is typically used in the management of cardiac conditions. But in this instance, those medications have been shown to improve the recovery rates in people who have facial paralysis of a traumatic origin. And so we often can use those for facial paralysis patients of a sudden origin as well. So for many people who have facial paralysis that doesn't recover, the most harrowing difficulty is this condition called synkinesis. And what that means is that you do get recovery of the nerve to some degree, but when the nerve grows back, it's miswired. And so now when you're trying to send a signal to raise your eyebrows because you're interested in what someone's saying, instead your whole face contracts because you can't actually decipher, your brain is not able to decipher, and the nerve is not able to decipher exactly where you're trying to send that signal. So that can be a really difficult thing for patients. So not only is that side of the face weak because it didn't get full recovery of movement, but when there is movement, that movement isn't really directed the way you want it to be. And so the way to treat that, the best way to treat synkinesis is really when we are able to use a neuromodulator or something called a chemodenervation. These are fancy medical terms. Basically means Botox. And we take Botox and we can use it in really strategic areas to do two things. One is to reduce the input to areas on the affected side of the face that we don't want. For instance, we're trying to close our eyes, but the entire side of our neck contracts because the nerve is unable to distinguish between those two areas. So we're able to put the Botox in your neck, in the areas of the superficial muscles of the neck, so that that's no longer spasming and contracting when you're trying to do something simple like close your eyes. At the same time, we're able to put some Botox or one of the other botulinum toxins into the opposite side of the face to try to reduce the relative hyperfunction on that side, because one of the other things about facial paralysis is you're dealing with the spasms and the dysfunction on that side, but then you have this exaggerated outcome because the opposite side is still completely functional. And so by reducing some of the movement on the unaffected side, we can get people into a more harmonious balance with their facial movements. And it also helps with their neuromuscular retraining because they're getting the proper signals back from their brain when they look at themselves, and they're not seeing full movement, so that then it kind of stimulates them to move even a little bit harder and have their nerves rewire essentially. Fortunately, there is a really cutting-edge surgery that's available for people with incomplete recovery after sudden facial paralysis called a modified selective neurectomy procedure. This is a procedure where we can actually go in and elevate the tissues of the face, exposing all of the nerve branches and then stimulating the individual nerve branches in order to see what their function actually is. When we see nerve branches that are creating a function that would be undesirable, for instance, when you're trying to smile, the lip pulls down instead of up. We actually transect those nerve branches to reduce and eliminate that input. So that's a very cutting edge thing. It's probably been available for the last 3 or 4 years nationally, and it's been available in my practice for the last 2 years. I learned from one of the pioneers in the field directly, and so it's a pretty unique thing that we're able to offer here at MedStar Georgetown University Hospital, and it's been giving patients a lot of hope that they can restore their face to a better place than it was before the surgery. There are a lot of other surgeries for facial paralysis, things for people who have either facial paralysis that's complete and doesn't return at all, maybe from a resection of a tumor or a trauma to the facial nerve. These are things where we actually will take, for instance, a muscle tissue from the leg, move it to the face, and then power it with a nerve from a different area that is enables the muscle to get a signal that can be controlled volitionally or voluntarily to give you some sort of facial movement and to simulate normal expression, even if it's not spontaneous like it would be in an unaffected face. For people with sudden facial paralysis, if you have not had complete recovery within the first 3 months of the facial paralysis, we often will at least have our first conversation about some sort of procedural intervention to optimize your outcome and optimize your overall condition. The first step is often the treatment of the eye. It's really important to get the eye fully closed in patients with facial paralysis. If the eye isn't closing fully, there are a few things that can go wrong. Number one, you can end up with some pretty long-term and serious consequences to your vision. But number two, the rest of the face really tries to overcompensate, and that's where we end up with this condition of synkinesis, where the entire face is contracting just to get the eye closed. So I'm pretty aggressive. Within the first 3 months, if a patient has not gotten full recovery and complete eye closure, I'll offer any of a number of small procedures that we can do to help get the eye closed a little bit better while they're healing. After that, it's really a conversation between me and the patient of what they're ready for and what the trajectory of their recovery is. I would rarely offer a procedure like modified selective neurectomy until the patient had been at least a year out from their onset of their condition and had shown a relatively stable time course and symptom complex before I would offer to do a surgery. You know, we don't exactly know how this is going to evolve over that first year especially, so we have to be a little bit patient in waiting to offer those bigger surgeries. In terms of patients who have complete facial paralysis of a cause different than a sudden facial palsy from a virus, so people who have facial paralysis from a cancer treatment or from a trauma where their facial nerve was transected, we intervene immediately. We know that from the literature on nerve recovery that the earlier we can get power to those nerves, the more likely they are to have a good outcome and to be able to regenerate. Nerves are pretty amazing things. Actually, it's one of the few things in the body that will actually regenerate, but it doesn't regenerate fully, and we need to do everything we can to assist that regeneration. And so with patients who have a known complete facial palsy and don't have really any reason to believe that that palsy would recover, so a tumor on the nerve that was removed, we'll often intervene pretty quickly to get the optimal results. Thankfully, at MedStar Georgetown Hospital, we know how to take care of patients with sudden facial paralysis to the best of our medical understanding at this day and age. And so I know that when patients come in here with a sudden onset of facial palsy, they're going to get the best available treatment. And that just makes me feel good every day when I come to work.